How about we go ahead and get started, as there are a number of questions that have come in today. So good morning to those joining us from the West Coast, and good afternoon to those here on the East Coast. Muscular Dystrophy Canada and Jesse's Journey are pleased to welcome you to today's information session. And we're very pleased to join forces to hold this session on returning to school for children with neuromuscular disorders. Many parents, caregivers, and family members have reached out to us, as I'm sure they have with also our clinicians and their own local school boards, about questions about returning to school and the difficult choices they have to make about returning to school with a child with a neuromuscular disorder. This information session is designed to help parents, caregivers, and guardians of children with neuromuscular disorders weigh the risks and benefits of available educational options to help them make decisions about sending their child back to school. This is an opportunity for you to ask questions, and there were questions that we received ahead of time that we will be covering today. We are very pleased to have Nicola Worsfold, who is the Director of Research and Advocacy at Jesse's Journey, and she's also a parent of a child with Duchenne muscular dystrophy. Very grateful also to have Dr. Ronald Cohen, President and CEO of the Hospital for Sick Children in Toronto. Dr. Laura McAdam, clinician investigator, pediatrician, who leads a large multidisciplinary neuromuscular clinic at Holland Bloorview Kids Rehabilitation Hospital. Dr. Reshma Amin, who's a respirologist and sleep physician at the Hospital for Sick Children and an investigator with the Neuromuscular Disease Network for Canada. We also have representation from the Toronto District School Board. We have Angela Nardi-Adessa, Systems Superintendent in Leadership, Learning and School Improvement, Special Education and Inclusion from the Toronto District School Board, and Janine Small, Centrally Assigned Principal, Toronto District School Board. I'll turn it over to Dr. Cohen for some opening remarks about return to school considerations.
Thank you so much, and welcome everyone to this webinar. And before we start answering your question, I just wanted to make a couple of introductory comments to set the stage. So why are we even having this discussion? I think it was fairly early on in the pandemic, at the beginning of May, when we realized that COVID is going to stay with us for quite some time. And while I certainly cannot predict how long it's going to be, but it's going to be at least another year, if not even longer. A group of pediatricians really across all of the children's hospitals of Ontario came together thinking about advocacy as almost like an easy way out to speak about what we were beginning to see about mid-May, end of May, which was the physical and mental health impact on children who have been isolated due to the pandemic. But we took it upon us to take it one step further in trying to develop a document that really is a guidelines document of how can we open schools, because one thing is very clear: we cannot go back to how schools were open before. And I think we all as hospitals recognize the tremendous amount of work that the schools are now going through, similar to what we had to go through, keeping in mind that we are healthcare institutions and schools. The task for schools is even that much bigger in terms of creating the most safe and healthy way for children, teachers, and school staff to go back to school, recognizing, and that's very important, that we won't be able to eliminate risk. And this is really an exercise about balancing and mitigating risk as much as possible. And while I'm sure we're going to talk about a lot of these different measures, there are a couple of important things I want to emphasize. First and foremost, all of this starts with you and all of us as a society. If we can keep community transmission low as it is right now, where our cases in Ontario hover around 100 per day, then I'm fairly confident that we will be able to open schools in a safe and healthy way. But we need to remain vigilant as individuals, with our families, in our own social circles, making really smart decisions over the next few weeks and the weeks to come, so we can keep community transmission low. At the end of the day, there is no evidence from any country, including Israel, who had massive school outbreak, that school is driving community transmission. It's usually the other way around. So we have to keep community transmission low. The other point I would like to make is there are a lot of discussions around single aspects of the mitigating risk measures, whether it's masking, physical distancing, and these are all important. But at the end of the day, the most significant impact we will see on safety is if we look at this as a bundled approach. And I think that's sometimes missed in our discussions. So we really need to try to implement as many of the health and safety measures as possible. The more we can do so, the more we are going to balance and mitigate risk. The only point I'd like to emphasize out of these bundled measures is something which I think will be yet another huge behavioral change that we have to go through as a society, which is we cannot, under any circumstances, send our children back to school if they're not 100% healthy, similar to if we have to go to work somewhere, or if a teacher is not 100% feeling well, we cannot go to school. I think we are all guilty of this, sending our children to school if they're not 100% healthy. All of this has to change as we move forward. And allow me to end with a general comment. I think that the discussions around opening of schools have exaggerated over the last few weeks to a degree that I think causes significantly more anxiety than I think we need to have. I think it's fair to say that all of us, including myself, who is sending one child to school, we all have certain anxieties around the virus, around the uncertainties that it brings. But I think we need to try to keep calm as much as possible. I am the first to admit that there are a lot of uncertainties, but one thing I do know, that the only way, and really the only way, we will be able to get through this is if we all work together and listen to one another in a civil and respectful manner. So let's make this happen. I know we will, I know we can, and I know we will prevail in the end. After all, we are talking about our children, which are the future of our society. So let's make sure we don't forget about them. Also listen to our children, which really have been the unheard voices of this pandemic. Thank you.
Excellent, thank you so much. The way we have organized today's webinar information session is in different categories. It might be comforting for some of you to know that the questions that came in, there was a lot of significant overlap, which means that you're thinking of the same questions as you're weighing those risks and benefits. One question and category that came up is around risk, as was just mentioned. We had Dr. Reshma Amin present at one of our webinars earlier in the summer around respiratory health, and what she spoke about is we know about risk for COVID-19 in terms of a theoretical risk. We want to return to that today. Is there any new or additional evidence around potential risks and long-term effects of COVID-19 infections in children with chronic neuromuscular conditions like Duchenne muscular dystrophy? And what is the update in terms of risk for children with neuromuscular disorders? Perhaps I can turn it over to Dr. McAdam to start this, discussion.
Thank you so much for organizing this discussion today. I think it's also excellent. Dr. Cohen and Dr. Amin will likely want to weigh in on this question as well. And so as it stands right now, we don't feel in general that children with neuromuscular conditions or neurometabolic conditions are at increased risk of catching the virus. So they're likely at the same risk as other children. However, they are potentially at risk of increased complications of this virus. And so when we think about viruses, and with COVID-19, it can result in pneumonia or lung issues. And so that's where we're concerned with some of the children with neuromuscular conditions if they have weaker breathing muscles. And I can let Dr. Amin talk further about that, but the risk of catching the virus is not increased. It's more the potential complications from the virus. With that being said, there have been very few cases reported of this virus in children with neuromuscular conditions. So this is really a theoretical risk. And I think over the next multiple months, we'll have greater understanding of what this risk truly means. Definitely, there's a wide variety of respiratory muscle weakness in different neuromuscular conditions. So there are going to be some children that were more concerned, not just about this virus, but also about influenza and the risk from a pneumonia standpoint. I know personally, I've received many phone calls from families asking about corticosteroids. So in Canada, many of our children with Duchenne are treated with deflazacort. There are some treated with prednisone. And this can suppress the immune system, but we haven't seen a lot of evidence that it is resulting in increased complications from COVID-19. And I would say I haven't seen that with other respiratory illnesses. So when I'm looking at influenza or other respiratory illnesses, but if you have weak breathing muscles, then you are at increased risk once you have the virus. But I'd like to open this up to both Dr. Amin and Dr. Cohen in case they have other insights on this.
Reshma, do you want to go?
Sure. I don't really have a lot to add to what Dr. McAdam has already very eloquently said, but maybe just to give some practical tips in terms of which, of our children and adults who have a neuromuscular disease, who are generally the ones, how would you know if you're at more risk from a muscle weakness perspective involving your breathing muscles? So when you come to do your clinic visits with the neuromuscular clinic or the respirology clinic, your child will be doing blowing tests. And as the muscles progress, you may start to be screened for sleep and breathing problems at night with a sleep study. And you may start to be needing assisted cough devices like a cough assist or lung volume recruitment. So in general, the children and adults we're most concerned about are those who've progressed so that they're already needing assisted ventilation. So that's in short, needing to use a breathing machine, which typically starts to be used at nighttime and then in the daytime. Usually your healthcare team will be recommending those for your child or as an adult patient once the breathing muscles get sufficiently weak. So I would say if you're being screened for those things and if you're already prescribed a breathing machine or a cough assist machine, you probably have more risk than children who have not already gotten to that point. And I think secondly, I would think of COVID-19 in terms of risk, just like you think about other things like the flu virus. So I think what's very important is although we're focusing a lot of attention on COVID, it's hard not to. I think please don't forget about the other viruses and infections that are out there and the things that we can do that are preventative for those. So generally, we're advocating very strongly for flu shots this year as well. Good hand hygiene, which cannot be said enough, especially in the era of the pandemic. And then also making sure that your regular vaccinations are up to date, in particular vaccinations that help protect against different pneumonias, like Prevnar and the Pneumovax vaccination.
So just quickly, two other things to reassure you. There is a group of over 100 neuromuscular physicians from all across the world, and all of us interacting electronically with each other periodically to update our experiences. And while there have been a few neuromuscular patients who have contracted the virus, there have not been any more severe complications in these patients so far. But we are watching this because it is probably safe to assume that most of the children who have these underlying conditions have probably been even more so isolated than other children. But I want to share one comment with you that one of the mothers of one of my patients who doesn't have a neuromuscular disease, but it has a very complex medical condition, shared with me after I spoke to parents from the medical complex care community. She said, parents like us have always been concerned about sending our children to school, just in line with what Dr. Amin just said in terms of the other viruses. If we are now sending our children back to school with a number of these health and safety and hygiene measures in place, she per se feels better about sending her kids to school than ever before. I'm not suggesting that all of you feel like this, but it was an important perspective for me that I never thought about, and that's why I want to share it with you.
Wonderful. Thank you so much. How about we go into, go ahead, Nicola.
Thank you. No, thank you for the comments. And just to clarify then for our families that are listening in, would you say then that COVID-19 is similar strategy with regards to risk as families would be dealing with the flu season? So obviously all of us are cautious of the flu and taking precautions. Is it fair to say then with COVID-19, it's very similar in terms of what we're facing to the flu?
Yes.
Perfect.
Yeah.
Thank you.
Excellent. This is also in that risk category. We don't have to go in depth, but perhaps it can be summarized more so around whether, if we're thinking about older children or adolescents, are they at greater risk? So an individual who has SMA or Becker muscular dystrophy, who's deciding to live on campus, even though they are engaging in remote learning, are they at greater risk? Being older is perhaps part of this question, or also engaging in those types of environments is the next piece of this question.
I mean, I can start with this. Really, I'm going to be borrowing on the information when they're talking about individuals who are slightly older. So the evidence that's out there right now is the risk appears to be lower in children who are younger. So depending on which report, so 10 and under, 9 and under, and then you have in your adolescence, there may be slightly increased risk of complications regardless of having a neuromuscular condition. And then the same is being said for individuals who are in their 20s or late teens and 20s. They are at a slightly higher risk of complications from the virus regardless of having a neuromuscular condition. So when I'm looking at the question about university housing, I know universities are being thoughtful around the discussions they're having and looking at reducing crowding, increasing physical distancing and spacing. And so I'd want to make sure that this family has had those discussions either with the university or with their daughter about what she's going to be doing to help ensure physical distancing, good hand hygiene, consideration of wearing a mask if you can't confirm physical distancing, and also bringing back to the point that Dr. Amin and Dr. Cohen talked about earlier about the importance of having a flu shot, because we really want to ensure we're reducing risk of other viruses. And that is one virus that we do have a vaccine that can help with, as well as your routine vaccinations.
Excellent. How about we move on to the next category of questions, which is around family members. So again, in that whole realm of risk, but what about if a family member is a teacher, an educator, an administrator in a daycare center, in the school? As an adult, are they putting their child at risk for continuing to go to work? Do we have information about that in terms of a parent to a child with a neuromuscular disorder or family member?
So I can start with this one. This is one of the most complicated questions to answer, but I'll try my best. Couple of things. By and large, it's the adults that infect the children and not the other way around. So if you are a teacher and you're the parent to a child with muscular dystrophy or any other neuromuscular condition per se, it really then depends on how the school you're working in is able to implement this bundle of safety measures that I spoke to you earlier, which is then going to significantly reduce your risk of being infected in school. whether that's from a colleague. I'm not saying that children don't transmit to adults. This is another highly controversial issue right now. But by and large, it goes the other way. So I think it really depends on here, if you have the safety measures in place in school, and that will be my expectation, then the risk of coming home is probably not significantly higher. There have been discussions, and I know a number of my colleagues have been recommending that teachers do similar things like we do here in the hospital if we have very intense patient contact, which is coming home, changing clothes, go take a shower, and then interact with the children. It's a bit of an extreme way, but but I think most of my colleagues have been suggesting this, particularly to the teachers who teach the younger children. And although the risk is much lower in this age group, but there's much more contact you have. So an added level of security would be to come home, wash your clothes, or put them away, and take a shower, and then interact with your children.
This is a really important question, and similarly to the guidelines we have for going back to school, is there a plan to put together or publish any guidelines for, you know, how to mitigate risks at home? Because I think a lot of our families, you know, for the most part, we've been at home, and as we've been in our bubbles at home, we haven't been practicing, you know, any of these risk mitigation strategies. And so going back to school, and for families who are going back to work, it is going to be a change in what we're doing. So is there a plan to publish any type of guidelines that might help those families at home as well as at school?
So I don't know the answer to this, but I think it comes back to what many others who had to go back to work have been doing. It's not so much about the choices in your house, but the choices outside of your house that you have to carefully make. And these are things like, do you have to go to the gym? Do you have to go inside a restaurant? And I think many of us who have been working through this entire pandemic, even when the opportunities have allowed some of us to do this, we are making a decision not to do it in order to keep our families as much safe as we keep people around our workplace safe.
Hi, if I can add, it's Angela Nardia-Dessa from the TDSB. And to your question, Nicola, we at the school board are creating protocols and guidelines for staff, but in regards to families, it's through our students where we are creating social stories or videos for the families to see and use with their children. So it's through the students that they see the guidelines that we're teaching our students to do at school and both at home.
Yes.
And just to add two additional comments for you, Nicola. I think the first is that a large group of people across the province are working on some specific guidelines for children with medical complexity and how to ensure sort of safe return to school. So I think a lot of those recommendations, they're going to talk about masking and cleaning, and a lot of those things will be transferable to practices that can be applied at home, I think is the first thing. And I think the second thing to consider, I'll be interested to hear if Dr. Cohen and Dr. McAdam agree, is another layer to this that can be considered as sort of the approach that we take when we're going back to healthcare, is if we are symptomatic, because we are appreciating that there's, you know, a large risk in terms of working very closely with other children and families, is, you know, as a teacher, if you are symptomatic and you have a child at home with a neuromuscular disease, then, you know, the suggestion would be to very, very quickly get tested for COVID through public health. So that would be another thing to be keeping in mind, in addition to changing the clothes and doing as best as you can with hand hygiene and other public health precautions that are being recommended.
Perfect, thank you. Just to add to that as well then, because this also applies to not just the individuals, but the family members within that household. And so if a family member in the household is sick or experiencing any types of symptoms or feeling unwell, should everybody in that household then stay home?
So So no, the answer to this is no. If one individual in the household doesn't feel well, this person needs to get tested. And then based on that result, you will closely work with your local public health unit. So for example, if you turn up positive, then the local public health unit will create a testing and tracing strategy for your social environment that may then extend now into school and so on. But you don't have to immediately stay home. I think what I've heard a couple of days ago, I do think Public Health Ontario, together with the local units, is working on some more clear guidance. These are a lot of the same questions that we receive, and I think it's also something that the school will need in order to know what are we going to do if a teacher becomes positive, if a child in the class becomes positive. I think you will have, though, very strong guidance from public health around this.
Before we move on to the next topic, I think it is important to more clearly then also answer this question about siblings who go to school, but the parents opted or have opted for their child with Duchenne muscular dystrophy or any other neuromuscular disorder to stay at home and do online learning. So would the same types of strategies apply in terms of limiting risk for that sibling who is learning outside the home? Dr. Amin?
Yeah, I think a lot of the same strategies can be shared. And I mean, I think first and foremost, I think it's important just to highlight that, you know, the decision about what to do is really going to be made by the family weighing the risks and benefits of their individual circumstances. It's very challenging to make blanket recommendations because there's so many unique considerations for each child and family and adult and spouse and all those things. But I think in terms of, to go back to Homira's question, that if there is a child who has a neuromuscular condition and the family has chosen to have virtual learning for that child, for the other siblings in the house, I think a lot of those same strategies can be used in terms of good hand hygiene as soon as you come home, changing your clothes, consider even showering as soon as you get home, and then very good screening for COVID-related suspected symptoms at all times, and then also thinking about other risk protection strategies, flu shots for the whole family, good hand washing for the whole family. And I think a lot of those things can help decrease risk, although not eliminating risk completely, but decreasing risk.
Fantastic, thank you. I believe now we're going into a topic, again, these questions are also about family members. So we'll move on to the topic around school plans and considerations. And we're so grateful Angela and Janine are here to represent one school district, and hopefully we can leverage these learnings for other districts as well. How about we move on to the next question, however, if the school board can comment on remote learning and clarify if this will be synchronized with each student's individual classroom.
Okay, great, thank you. So before I do answer that question, I do want to acknowledge something Dr. Cohen mentioned in regards to high anxiety that is being experienced from our family, our staff, our students. And I'm glad to see platforms such as this directly addressing the anxieties and the fears. So thank you so much for doing this. And we continue to do this through ward forums to our community. So again, thank you. So in regards to virtual learning, I'm sure you're all following the news, and it's a moving target with the different plans that continue to evolve. Just as recent as yesterday, our board approved yet another plan to move forward based on some of the decisions that was shared through our ministry. And so we are quickly trying to now pivot to this new direction. And so we, like many boards, have sent out what we're calling a registration, where parents will be informing us if they will be sending their students to school face-to-face or choosing the virtual or remote option. Numbers seem to be significant where we are now working towards what we're calling a virtual school. And so that will impact, of course, staffing, and we don't have the answers yet of how that would look like, because as I said, up until last night. And so as we are processing what virtual school will look like for students with special education, I do want to address some of the concerns that have come forward from our families, such as if my child with special education needs was given a special classroom, an ISP classroom at a particular school, and now they choose remote, do they lose that school and that placement? And so the answer is no, because one of the things we want to make sure with our students with special education needs, whether it's face-to-face or remote, is equity of access. We're trying our best to be mindful of any barriers that might be placed that would interrupt students' successful return to school, again, whether it's face-to-face or remote learning. In regards to synchronized and asynchronized learning, again, we want to be very mindful that that will look different for each student and for each family. We're asking our schools to, once we have the list of students who are doing remote learning, and you're creating learning goals based on their IEP, to take into consideration what their remote learning environment is. In other words, we can't say at 11 o'clock, go to your backyard and do, you know, some exercise, because not all students may have a backyard. And so we need to be very mindful of our language, of our strategies, that they actually meet and cater to the needs of our students and our families. Also in the timing. So we need to make sure that the synchronized timing is appropriate for our families, because we know some of our families have different things that they're trying to manage at home, as well as now supporting their student with special education needs virtually. So being mindful of that. Also being aware that some students who choose remote will not be able to do it digitally. And so we are trying our best to prepare to support families and school and students remotely using non-digital resources. And so we're pursuing that. And again, a case-by-case basis, because what might work for some families may not work for others. So in essence, what we're trying to do is be as supportive as we can to family and student needs, ensure that the synchronous and asynchronous learning happens, ensure that if they do choose remote learning, they do not lose their ISP placement, and making sure, again, equity of access for all students, to whichever platform they use, if it's remote or face-to-face.
Wonderful, thank you. I believe you started to address this in terms of if the child is in an ISP classroom intensive support program for part of their curriculum, is this something that will be extended to cover the full curriculum to reduce the exposure to the child? The ISP classroom typically has much fewer students in this case. Will all ISP students stay in the same room, or will they be integrated into the main classrooms? This is important because ISP students tend to be from multiple grades, 1 to 4, 5 to 8. Is there a plan for this?
Janine, I'll pass that to you.
So our plan is to ensure that the support is provided for students based on the decisions from IPRCs. So if the IPRC decision is special education class, then whether parents choose remotely or in face-to-face, we try to honor that to ensure that they are being taught by a special education teacher. And most of our ISP classes do have that sort of 3 grade span depending on the student. So we try to keep that as much as possible. And again, some of it does depend on the staffing, but for sure, we try to make sure that students are according to the decisions from IPRC, whether that be in full ISPs or regular class, whatever the support is, we will try our best to support that as much as possible.
And if something to consider is if we have a high proportion of students who choose virtual school, they may not have the teacher who they had last year or the teacher that they're hoping to have. In other words, we may have 2 students from one school, 2 students from another school, and 3 students from another, who will now all come together virtually to create an ISP virtual class, and a different teacher that they may not know, most likely, will be assigned to them. And I know that's causing some anxiety for families because they love their teacher and they love their school. And so we're working to ensure that part of that virtual school starts off with really understanding relationships, building trust, and of course, programming a robust curriculum, ensuring a robust program, but really focusing on that is something that families are struggling with, and that is the new reality. So we're trying to make it as a soft landing as possible.
Excellent. Actually, a question that came in live that I think is appropriate to ask is around if a child and a family opts for remote learning, will they have access to an educational assistant? So face-to-face, they traditionally had access in EA. Now, if they opt for remote learning, what are the plans in that scenario?
Yep, so they will have access. And so I will pass that on to Janine.
So typically in some of our programs that have intensive support programs, there's a teacher and a support staff. So we will try to continue that support through an educational assistant. If students are in regular classes and they had access to an EA in the school, then of course they would continue to have that support. I know that with some of our students in terms of their physical needs and having SNA support, well, staffing is still available. It just might look differently, but that support would be there. And as soon as we have a clear understanding of who are the students that are returning and what context, we will be able to continue to provide some of those support because the staffing is still there to provide that.
Great. This one here is about whether school boards would consider delaying or staggering school starts to help them to feel comfortable and ensure that all measures have been implemented and working properly. Is there a plan for a staggered or delayed start?
Yes, so that was part of the voting of the trustees yesterday. And so some of the things that they voted on were the staggered start of September 15th. So all students with special education needs will start September 15th, so that week. And then the following week, all other students, in regards to busing, depending on if we have enough bus drivers. The goal is for, we worked with TPH to look at high-risk areas within the city. So schools that are in the high-risk areas of COVID will have a ratio of 15 students in kindergarten and 20 for grades 1 to 8. In regular school, in areas where there is no, the COVID is not as high, so they're calling it the regular areas, we're having kindergarten numbers at 20, grades 1 to 3 at 20, and grades 1 to 8 at 27. So, so that's that piece and staggered entry. And then there was a second question. I can't remember what you asked.
Let's just go back. It was around, yeah, delayed and staggered start. But actually, let's move on to this question here. You just mentioned bus drivers. Is there, you mentioned whether they'd be available, but is there a screening for bus drivers? And will there be a screening prior to a child getting on a bus?
So that is looked after the actual bus companies. So yes, we're still not sure if we have enough bus drivers. So fingers crossed. The company is doing everything possible to procure them. In regards to screening, so my understanding is that buses the bus drivers themselves will be doing the high touch surface areas in between runs. There is a screening before the kids come onto the bus. When the students arrive at the schools, support staff will assist the students coming off the bus, will bring them to the front of the school, where then the school will do their screening before entry.
Very good.
And just a few more things for busing. To support contact tracing, school bus companies will create seating plans in collaboration with our schools so that we know who sits where. They're saying they want to keep the windows open, and we are making sure that we know which bus routes are using, which buses are being used to also transfer our coterminous board students, so that we have the names of those kids as well.
Perfect. Thank you, Angela. Can we go back to the class size discussion? I know that this is a big concern for many families, particularly in schools where they're not able to, limit the number of students in a classroom. And, even though, for example, the older age groups you mentioned, the cap being at 27, and 27 is still a large number of students in one class, that's where social distancing is going to be much more difficult. I was wondering if Dr. Cohen or Dr. McAdam or Dr. Amin could maybe comment on the potential sending kids back in a scenario where they're in a classroom where they can't social distance, and what sort of risk mitigation strategies can be considered in those situations.
Yes, I'm happy to start on this one. I think we made it very clear that there's a minimum amount of 1 meter of distance that should be implemented for any class size for the younger children, and 2 meters for the older children, because the transmission risk is higher there. Now, there are a number of children who are older, and I think, if I'm correct, Angela and Janine, and please correct me, but I think you are now mandating masks for all children at all ages, correct? So before that was announced, we try to reassure parents that in middle school, for example, or grade 4 and up, even if there is no social distancing possible, the masking then is going to balance that risk. So in general, and we keep forgetting this, the official public health recommendation is to wear a mask in indoor spaces whenever physical distancing is not possible. So now with the Toronto, with the TDSB and a number of other school boards, I think, have joined you in your efforts to mask all children, the physical distancing becomes less of an issue if all children are masked, and coming back to what I said before, all the other health measures are in place, like hand washing and so on. So there's maybe some reassurance here for parents.
Thank you.
Great. Just being mindful of time, I want to move through this category, but I think one topic, if I can capture the next set of questions, it's more so, Angela and Janine, is there going to be contact tracing? Is there an app? Is there, if a child is off sick, will they have to bring back COVID-19 test results? How, is there a process or protocol in place around that?
So thank you for that. We are working through that. So right now, what we have been directed through TPH is that if a student or a staff exhibit any symptoms of COVID, or simply saying that they're not feeling well, that we bring them into an isolation room. So schools have been directed to create an isolation room. The school board has provided isolation room kits, so that there's gowns, masks, face shields, gloves, everything you can think of. and the family is then contacted to come and pick up the student. And then once the family calls us back to let us know that yes, it has been confirmed, we follow up again with TPH and follow their direction. So really whatever TPH tells us to do is what we will follow.
Great. And just for clarification for everyone on the call, you're referring to Toronto Public Health.
Correct. Yeah, sorry.
No, that's fine. Let's go ahead and move into the next category, which was around social interactions. Some families have emailed us to say, you know, when we did in the spring do remote learning, we realized that it did impact my child's social ability, social skills, their independent skills. And so is there an opportunity to engage in social interactions if they're outside or, you know, joining over lunch if there is as part of remote learning?
Yeah, that's an interesting question. I met yesterday with SEAC, our Special Education Advisory Committee, and they actually brought up the same concern. And so we are meeting with our virtual school team to help sort all of this out. And one of the pieces was, can we do social groups where they can come together, sort of like an extracurricular, if you will, done virtually. And so that for sure is something that will land in our planning. I can't comment that, yes, that's what's going to happen. I think it's in the best interest of our students so that they can stay connected and continue those relationships. And in fact, it was extended to say, is there any way that we could bridge this connection to our homeschool? So because the students really want that connection with that teacher and that friend. And so we're trying to figure out, can this extracurricular half hour where people can just join in, can it include, you know, more than one school so that they can all come in? I mean, I don't see why not. It's just really trying to work it all through, which we can. We just, you know, need the time to get through it. But absolutely, we think that's critical to really support their mental health and well-being.
Excellent. I know there was great mention already about hygiene and masks. One question is, what strategies would you suggest for a child who does not like to wear a mask? We had a parent who had a child with RYR1 with malignant hypothermia and said, you know, throughout the day they remove their clothing. I can imagine that they'll remove a mask. Are there any strategies, Dr. Amin, Dr. McAdam, Dr. Cohen, that you would recommend to this family in terms of having their child wear a mask for 8 hours a day?
That's a great question. I think there's a lot of, I mean, I think the recommendations put forward are for masking. However, I think it's important to mention that there's going to be a large, you know, group of children for whom masking is not possible for multiple different reasons. So number one, it could be that a child is just not going to be able to wear a mask because they have some kind of skin sensitivity, physical sensitivities. They're not going to be able to wear a mask. The second is that masking is not being recommended for children who are not able to remove the mask. And thirdly, there's a subset of patients, of which many neuromuscular patients will fall into this category, for whom, as clinicians, we're worried a lot about the risk of rebreathing carbon dioxide, which is the gas that we exhale from our lungs, and not being able to clear that because children are so weak from a breathing perspective. So there's multiple different sort of sets of children who are not going to be able to wear masks at school despite this recommendation to wear masks. So I think that's first and foremost. I think in terms of a child who you're trying to get acclimatized to wear a mask, who doesn't meet any of these sort of three outright sort of recommendations against a mask, I think is probably like anything. It's just persistent practice and encouragement in a positive, fun, playful manner. That's what I would suggest. And then I think, other than a mask, the question about should my child wear a face shield. So generally masking is recommended. In certain situations in the healthcare setting, face shields are also recommended for healthcare providers interacting with that child. I think at this present point in time, it's not being recommended that a child wear a face shield or wear eye protection. It really is masking a good hygiene, and then wearing additional protection is really for individual healthcare workers or EAs who are going to be interacting with children in that less than 2 feet physical distancing criteria.
Maybe let me add to this, because I can tell you the most controversial issue of our document, not just outside in the public, but even inside among the 38 pediatricians who wrote this document, has been the masking of children. With the majority really feeling quite strongly that masks should actually not be mandated in the little children. I would like to propose a more pragmatic approach to this. I mean, now where TDSB has mandated masks, I also think we need to be open and see how things are going to work with masks or without masks. The one term that we all need to keep in mind in the right context is that everybody has to remain flexible as the school unfolds. There will be a number of things. Schools, teachers, parents will realize this is not working well. I may have to change something. And that should be pleased by everyone, interpreted as a strength. Flexibility in this current situation is a strength. If you want to implement something and you see you may have to change something or adjust it, it's good. I want nobody to, I'm afraid that people will get nervous if maybe schools have to make a decision to change something, whether it's around masking or other things. We have been changing in the hospital, sometimes things on an every other day basis in the beginning based on new evidence that comes in, certain experiences we had, no matter how much thought we have given to certain strategies, we realized, oh, we have to adjust it. So I think let's just see how this works. In addition to what Dr. Amin said, there are a number of really, really good videos out there that show you how you can teach a child to wear a mask, how to take it on, how to take it off appropriately in really nice ways. Here in Ontario, TVO Kids has a Dr. Cheddar masking video, which is really good. Just go through this exercise before they go to school.
Great. I do want to get to, there are some questions, Dr. Amin, around respiratory, but are there rules, Angela and Janine, around if a child has a wheelchair? Are there any cleaning instructions, measures in place for that?
So there's, in regards to high touch surface areas, whether it's the change table, whether it's the use of the elevator or an OTPT equipment like a stander. So each school will be provided with the wipes, and caretakers will be doing wipes every twice a day for high touch surface areas. However, each class will also be provided with the wipes so that the support staff can also do the wipe.
Thank you. The questions here are around whether a family should bring a dehumidifier to a classroom. There has been some articles that they have come across about the benefits of a dehumidifier or humidifier. Can you speak to that, Dr. Amin?
Maybe just in the interest of time, just because some of the things on this slide sort of highlight this. One of the biggest challenges, considerations for us now is thinking about all the children who use certain respiratory machines at school that are considered to be aerosol generating medical procedures. So that's been a really important buzzword, both in the healthcare setting, but also something that we really are thinking carefully about how to do this safely for many of these children that we follow who use these technologies at school. So let me just clarify that. So the rule about 6 feet came about from regular droplet transmission. But when individuals use certain equipment, such as a tracheostomy with suctioning of the tracheostomy, you can generate these droplets that are in an aerosol form. And so the idea is that these will transmit further. And so in the healthcare setting, whenever we have someone in the hospital who uses these technologies, we've been putting them into sort of a private room. So one of the important factors for return to school is that we have many children who use these aerosol generating technologies like cough assist, like a tracheostomy with suctioning, like BiPAP or CPAP at school. And these are aerosol generating and require a different set of recommendations from a safety perspective. And so right now we're just working with school boards, the LIN, home care nurses, clinicians across the province and public health to figure out what is the best and safest way to be doing this. I mean, I think one of the things that we really want to highlight is that, we really appreciate the value of school, and we really want to make sure that these children have the opportunity to go to school physically, if that's what the children and families choose. But we're trying to come up with sort of the best recommendations to be able to do that. So some of these thoughts involve having a private space that these children can go to do these aerosol generating procedures, because they are very high risk. And if there are nurses or educational assistants who have to be interacting with these children during these procedures, they're going to be having to wear, more than just a mask when looking after these children during those procedures. So we don't have anything final as of yet, hoping to have something by next week. But I think we sort of go back to what Dr. Cohen has been saying throughout this webinar, is that this is our best guess for now. The truth is, we don't know if this is going to hold for next week, because we don't really know necessarily what the next few weeks are going to bring. And I think all of this is going to be very dynamic and changing, because this is the nature of COVID. In terms of bringing the question about bringing a dehumidifier to school, I'm not aware of the literature to sort of show, to make that recommendation. That's really going to be a big value add. I think one of the things that the schools are thinking about are ways to increase the ventilation in the different areas, because this helps with, that the air exchange and those things help with sort of the risk of transmission of these aerosols from children.
Excellent. Perhaps for this set of questions, I'll turn to Dr. McAdam. It is around a family described that their child had gained weight during virtual learning over spring. Any suggestions if they were to stay home, how to engage in physical therapy? And that joins us to the next question of if a child will lose out on physical therapy and speech therapy if they opt to stay at home. Any strategies on accessing those types of rehab services virtually?
So for the first question, many of the families that I've been speaking with, this is a challenge regardless of COVID. And I think in the time of COVID, when children have not had the same access to physical activity or movement, this has become an even greater issue. So the two main components in my discussions with family are, one, access to movement. And we've talked a lot about the risk mitigation strategies. And so such as physical distancing, wearing a mask, good hand hygiene. And so really looking at your day-to-day schedule, is there an opportunity to increase movement or physical activity while you are at home? A huge challenge for many families is access to pool and swimming, because many of the patients I see do swim on a regular basis, and many pools have been closed, and when they have been opening, many families still are not feeling that that's an environment they want their children to be in at this point in time. So it's really going to be looking at what opportunities can be created within the home setting. Another component to this is calorie intake. And I know in just the general literature, many people are talking about COVID pounds, and it's really having access to a food in a different manner. And so I'd recommend, from that component of it, is considering doing a food diary for a couple of days, looking at what food you as a family as well as your child is having access to. Are there potential substitutions, such as lower calorie options for similar types of food? or there may be snacking that you didn't necessarily recognize was happening on a day-to-day basis. I'd also recommend talking with your healthcare team. So this could be your primary healthcare team, your neuromuscular team, and trying to come up with different strategies to either incorporate some physical activity or some different dietary recommendations. Now, the second question, I think this one is really going to be a combination of us with the school, because if children are learning virtually and they have had access to PT or speech therapy, and if they're doing online learning, will they still have access to this? And so I'm hoping this is going to be part of some of the considerations from a school board standpoint. I don't know if anyone from the school board would want to comment about that.
Sorry, I'm multitasking. So in regards to the school board with this area, we are having conversations around how will students receive their physical education remotely. And so we're working through the phys ed teacher perhaps being timetabled so that the students have an opportunity to do the physical exercise, whether again in front of the screen, like get up your chair or off your chair. And if you can't do that, like just moving some parts of the body. And again, talking about the calorie intake with families, being mindful of equity issues in regards to the, snacks like fruits and vegetables are a different price range. So just really being mindful of what we share and how we share it. And yes, so how do we support our families with this concern that they have will be done case by case.
To that note, Angela or Janine, I don't know if either of you can comment on, resources that may be available to families or some suggestions for families in terms of who should they be reaching out to within their school system to really work with them to make sure that, their needs are being met, whether they are in school, so looking at safety measures in the school, or whether they're at home and remotely, what type of support? Is there someone that they can connect with, or would you recommend or direct them somewhere they can go to get their questions answered?
Yes, the best place is always to start with the school principal, so that, ask the teacher directly or the principal. And then the principal then becomes the liaison and reaches out to if they need support through social work, if they need support through early years literacy, a speech pathologist, whatever it is they need, it's always through the principal. So that would be the first place to go to.
Perfect. And just to follow up on that as well, a lot of us have the individual educational plans that we work together with our teachers in the classroom. I know typically the mandate is within the first month that they work with their teachers to update and develop that IEP. Given the state of affairs and that everything is sort of changing, would there be an opportunity for families to connect with those teachers, whether it's remotely or in class, ahead of time to really talk about those IEPs and how they may be changing given the new environment?
Absolutely. And I'm going to just go back to what Dr. Cohen said. Right now, flexibility and patience is our friend. And so teachers are going back to an environment that looks very different from what they left before March break. And so will students. And for some students, as I said, entering a virtual school with perhaps a teacher they've never met. And so yes, the clock starts from the day the students enter, those 30 days. And sometimes we have parents who, want action that first day. I wasn't contacted around my student's IEP, so he already lost a day. And so I implore families to be patient. We acknowledge the urgency and the importance of ensuring that IEPs are updated and honored. We need to have some time to support that relationship building, especially if it's a new teacher, to understand the student's IEP and learning profile, to talk to the parents, And in developing those learning goals, as I mentioned earlier, to be mindful of the family's remote learning situation and make sure that they cater to that and support them. In regards to that magic number 30, and it's funny because I was working on the protocols before we got on. Typically everyone had, you know, October 13, that's the magic date, or whatever date it was. We all shared that same date. Because of staggered entry now, we're going to have different due dates. And so in my principal's checklist, it was make a list of when students are starting to track those 30 days. And the last point is in regards to the parent collaboration. Absolutely. These IEPs cannot be created without their voice. They are the children's first teacher. And so contact, hopefully, even if the student is going face-to-face, the goal is that the conversations happen virtually because we want to minimize exposure and contact.
Excellent. Thank you so much. I appreciate all of your time and insights. This is an evolving situation as we're gathering more evidence and information. So I really appreciate each speaker's time, each panel's time to attend to the different questions that have come in. I do apologize if I have missed some questions that have come into the live Q&A or the chat box, but I have noted your questions and will individually respond. Feel free to email us at research@muscle.ca or visit Jesse's Journey's website, Muscular Dystrophy Canada's website. We appreciate the time that you took today to join our webinar, and again to our panelists for providing evidence-based, well-informed information, especially as the situation is evolving. Thank you all so much, and I wish you all a successful school year, whatever that may look like. Thank you all.
Thanks, everyone.
Good luck.
Thank you so much, Hamara. That was wonderful. And just a quick shout out to the families as well that are on the line. Is I know this is a really difficult time for everybody. We're making decisions about what our next steps are, but just, you know, feel confident there is no right or wrong answer. I think whatever decision you make, whether it be remote or in school, you know, it's an individual decision to make, and it's your decision to make whatever you're most comfortable doing. And make sure that you do reach out to your school principals, your school board, as well as your neuromuscular teams to help you make those decisions. So thank you, everybody.
Thank you.